Hello and greetings from Raleigh, North Carolina. My name is Dr. Ben Fisher. I'm speaking to you today from my clinic. Thank you for your interest in hearing about my topic today. It is defending the doctor-patient relationship. I have no relevant disclosures for this talk, and I will tell you a little bit about myself. I'm an internist. I appreciate being part of the family medicine community. I've been grateful to be a participant in FMEC conferences for the last 4 years or so. I'm going to be speaking to you today from my heart, and I have appreciated the heart that I see in family medicine, the desire to practice medicine with our whole heart, which is what I'm going to be speaking to you about. My training background, I went to Baylor, did my residency training and chief residency in the Navy. After completing my Navy service, I spent time as a full-time hospitalist before starting a group insurance-based primary care practice for 10 years before I started my own independent direct primary care practice. And I spent a good bit of time over the last 10 years developing a collaboration with the YMCA to help my patients get at the root causes of ill health and address chronic illness at its roots rather than at its dealing with only with its symptoms. What I'd like to talk to you today is near and dear to me and my own personal struggle to find my what I think is my true north in my medical practice, to spend my days doing what I think I'm supposed to be doing. And so in that discussion, we'll talk about the critical importance of the doctor-patient relationship. We'll identify the longstanding threats against what I consider our true calling as primary care physicians. And we'll talk about how we can overcome those threats for the good of our patients. I don't know where my listeners are in their careers, or if anyone who's hearing this may be able to sympathize with the feeling that I'll describe. Starting in about 2010, I began to have this strong conviction that the work that occupied my days was not the work of my calling. I felt that I was not doing what I was supposed to be doing. My patients were coming to me suffering from various things, from illness, from heartbreak, from disappointment, from fear and anxiety, and I was somehow not present for their suffering. I was busy coding, I was busy moving through my days more quickly than I felt that I should. I was not taking the opportunity, or in some cases deliberately avoiding the opportunity, to delve deeper into things that I sensed my patients really needed to get into, because I simply needed to get through my daily toil. And as I struggled with this separation between what I felt that I was supposed to be doing and what I was actually doing, I was helped a lot by conversations with friends and colleagues, and some of the historical criticisms of modern medicine that those friends and colleagues shared with me. And I'd like to read a few excerpts for you today that I think will frame our conversation and tell you about how I resolved those struggles in my life, and how I hope I can help you if you struggle with similar things. So the first quote I'll read before I reveal the source. It's a lengthy one, so have a listen here, and I'll project it for you. Amid all the worries that intermittently plague man, anxiety over money, strains of family, the larger fears of war, there is one always present, the threat of illness. It walks in every person's shadow, and when it strikes, the sharp sense of mortality makes itself felt. Through the ages, when beset by sickness, people have turned to the doctor as protector and champion. Honor and respect were draped on him. The relationship between him and his patient became a bond. Today, this relationship has been imperiled as patients dealing with their doctors are assailed by doubt. There is a mounting awareness both in and out of the profession that the job being done by physicians today is short of what it could be. Too many Americans have on occasion felt like the figure below, and I'll show that figure in a moment, a Gulliver, helpless in the toils of modern science, set upon by an army of doctors. He wishes each doctor would display more than a Lilliputian interest in one subdivision of his anatomy. He is aghast at the bills he will have to pay. He wonders if anyone will tell him what is really wrong, and he sees no one person who can give him comfort and courage. You may be surprised that this is a relatively older quote. It comes from Life magazine from the October 12, 1959 edition. And the diagram that's part of that article is shown next here. This is the Gulliver, who is laid out and set upon by an army of technicians. And in the diagram, there are two primary care physicians. You can see the one on a stepladder trying to have a higher view of the whole person as the technicians below him toil on individual parts. And then you can see another primary care physician off to the side near the patient's left axilla, standing outside and somewhat disregarded by the crowd of surgeons there discussing his patient. This gets to, our specific role as primary care physicians, trying to see a whole person, trying to oversee what is a technical endeavor, but it's a technical endeavor upon a human being. And it's our particular role to see the whole human being in the midst of that. I'd like to read the next quote, going back even a bit further in time, and some of you may recognize these words. I hope some of you have heard them before. The most common criticism made at present by older practitioners is that young graduates have been taught a great deal about the mechanism of disease, but very little about the practice of medicine. Or, to put it more bluntly, they are too scientific and do not know how to take care of patients. The treatment of a disease may be entirely impersonal. The care of a patient must be completely personal. The significance of the intimate personal relationship between physician and patient cannot be too strongly emphasized, for in an extraordinarily large number of cases, both diagnosis and treatment are directly dependent upon it. And the failure of the young physician to establish this relationship accounts for much of his ineffectiveness in the care of patients. So here's highlighted by the great Sir Francis Peabody in JAMA, published in 1927. Peabody is describing the critical importance of the doctor-patient relationship in allowing us to see our whole patient. We have to know our patient in order to see our patient. And this article from 1927 in the medical press, the lay article from 1959, helped me as I read them to make me aware that the struggle to retain the humanity in the practice of medicine has been going on for a long time. That struggle that I felt that I was not doing what I was supposed to be doing for my patients is a struggle that patients have felt, and that has been something that the medical profession was aware of for much of the 20th century, and perhaps longer, but to my knowledge, at least that long. And it gets at the growing perception as our technical abilities rose as in medicine for the relational competence of physicians to become less relevant and less important. So that rise of the technical has resulted in what we have now, which is a largely technological, very procedurally based and specialty based healthcare system. That procedural emphasis has not been harmful, has been okay for those in our profession who principally do procedures, but for those of us in primary care, we stand in a particular place between the technical and the personal. And our role in that is to help people, help shepherd people through the technical apparatus of medicine and shepherd people through the struggles of life while retaining their humanity. And in order to do that, we have to know our patients. Our scalpel as primary care physicians is our relationship. If we are not able to have relationship, we cannot do our work. And the system that has been set up to allow for the technical pursuit of medicine has largely excluded and devalued that relationship, so that we are swimming upstream as we strive to maintain that relationship in the context in which we currently work. I'd like to do a thought exercise that will help root us in, I think, remind us of what we're here to do. So I'm going to talk through this, but I hope that you will imagine that we're in an interactive session, and I'm going to ask you, as you're hearing me, to close your eyes and use your imagination. And what I'm asking you to imagine is the person, first off, I just want you to picture the person you most love in this world. Maybe it's a grandparent, it's somebody who has loved you purely and whom you love purely in return. This person is dear to you, and now I want you to picture this person sick. Badly sick, unfortunately, losing weight. You're fearful that there's something really serious going on. And now I want you to picture the kind of physician that you would like to see and attend to this beloved person. And I have done this exercise in other groups, and so I can tell you what sort of adjectives come to mind, and will put up on the slide for you the sort of adjectives that I have usually heard listed as attributes of the physician to care for the beloved patient. Kind, wise, thorough, humble, accessible, knowledgeable, careful. I wonder how many of you wrote your medical school essays about being this kind of physician. I know that I did, and this was what I thought I was out to do, and this was how I defined and would define a good physician. And now I'd like to have you close your eyes again and imagine now that you're no longer thinking about your this beloved individual. You're in a new role. Now you're the CEO of a large health system, and you have to keep your organization in the black. In order to do so, you know that your physicians need to meet certain metrics and outcomes, and have to perform in a certain way in order for you to get the payments from contracts that you need in order to keep your organization going. So now you are in the hiring process and you're looking for a position from this seat of power that you're in. So what kind of physician are you going to look for? And again, having done it in other groups, I'll list up the common attributes that are given. But the first two uniformly that are always given are efficient and compliant. Fast is important. You don't want dummy, smart, team player. These are common things that I have seen up there. And these are not necessarily negative attributes, but what I would like to point out with this thought exercise is that they are, you cannot both be kind and compassionate and careful and efficient and compliant. You cannot pay attention to the particular concerns of your particular patient while you're also trying to meet these ends of the health system. And this is the place where we find ourselves. This is the place where I found myself as a physician, trying to do the work of my calling, which is the care for the beloved patient, while I was also doing the work of the insurers and the health system. And I found that I could not do either one well simultaneously. I did both poorly, and ultimately I had to choose and decide who I worked for and whose interests I served. And I have come down in my own professional life firmly on the side of the patient. I serve and care for my patients. And it's my conviction that operating under that time-honored direction of honoring the doctor-patient relationship, not allowing any other parties between you and your patient, will allow you to take the best care of your patient. I'm an internist, probably principally because of Morning Report. I love that institution. I love case presentations as a way to learn. So I'd like to launch into a couple of case presentations as a way to turn this from an abstract thought process into something more concrete. So I'll present a case from 2006. This is the year that I was a hospitalist, and I was taking on cases admitted the night before. One of my new patients who I was assuming care for had been admitted for respiratory failure. He was a patient with metastatic lung cancer that had impacted multiple organ systems. He was on dialysis. He had hepatic failure, and he was saved from intubation the night before by drainage of malignant pleural effusions. The chart looked awful. The patient looked worse. When I walked in the room, this was anybody with any medical training would say this was a man very near death. He was in terrible shape, and I entered a room filled with many family members of varying generations, and I could immediately feel that it was a very tense room, and hoping to cut through the tension and communicate my awareness of the patient's suffering and my awareness of his nearness to death. I expressed as much. And as soon as I said anything about nearness to death, the heads in the room turned like heads swiveling in the movie The Exorcist, and holy fury was unleashed upon me for even uttering the idea that the patient might die. And I was chastened out of the room. I was requested to be dismissed from the case, which I was. So my whole interaction with this patient, other than review of the chart, was probably 5 minutes, but I've thought about it so many times over the last 14 years. And what I've come to realize is that I walked into that room and I pronounced what I believe to be a truth. This patient is dying. But I did that without any having earned the right to be heard. So that family didn't know me at all. I didn't know them. They had no reason to believe that I had their best interest at heart, other than hopefully I was a physician and therefore did, but they had no personal relationship with me. And here I was to talk with them about the death of this man before them. And this case for me highlights one of the difficulties of the system we have with hospitalists, which as you know, I was a hospitalist. And the whole notion of hospitalist is based on efficiency, that the primary care physician can more efficiently see patients without interruption in his or her office, while the hospitalist, whose expertise is in the hospital, can more efficiently work through those cases. And both hospitalist and primary care physician can have more leisure time as one of the benefits of this. But all the while, what is done in the name of efficiency, which is increasingly the holy grail of health policy, what's left out is the patient. The patient has nobody to care for him, to give him. There is no one person, in the words of the Life magazine article, who will give that person courage to face what he has to face, and will tell him what he needs to hear in order to navigate life and death. So in situations where our patients are admitted in a nearness to death, our efficiency has really let us down. And I'd like to read once more from Francis Peabody. The good physician knows his patient through and through, and his knowledge is bought dearly. Time, sympathy, and understanding must be lavishly dispensed, but the reward is to be found in that personal bond which forms the greatest satisfaction in the practice of medicine. One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. That patient needed somebody to care for him. I was a person there to deliver quote unquote care, medical treatment efficiently, but I was not there with relationship and able to help him in the way that he needed to be helped. I'd like to contrast that with a case of another patient whom the events I'll describe happened in 2018. This is a man who I had known for about 10 years at the time of this presentation in the clinic. He had had a remarkable renaissance from a severe cardiac condition in the mid-1990s when he had an infarction of his anterior wall and VFib arrest and multi-vessel bypass and resection of the aneurysmal segment of his anterior wall, all of which he surprisingly survived. And when I first met him in 2008, he was compounding that by being significantly overweight, diabetic, and uncontrolled hypertension. I was grateful after a few years of our relationship that he accepted my invitation to come to the Y with me, and he had several years of wonderful return of health and lost needed weight. It was a frequent visitor to our YMCA exercise classes, and we enjoyed some years of health together. And then in the late summer of 2018, on a hot North Carolina summer day, he was walking up a hill to a funeral and became profoundly short of breath, which revealed a progressive ischemic cardiomyopathy. As we tried to remedy that, he underwent procedures, stents, and the like, or at least attempts at them. His coexistent prostate issues resulted in post-procedural urinary retention and infections. And this day that he came to see me in 2018, he was febrile and sick, and I quickly realized that he was very sick, and we admitted him to the hospital. Actually, we had to call 911, and he was in severe sepsis from a multi-drug resistant pseudomonal sepsis from his catheter associated urinary tract infection. And he went on to somehow, this man was a remarkable survivor. He survived against all odds, sepsis with multi-organ system failure. And since I was now admitting my own patients to the hospital, I rounded on him daily in the unit as a courtesy. And then I became the physician of record when he was transferred out of the unit about a week later, and then cared for him through the duration of that hospitalization, which had all kinds of complications and difficulties. I was in and out of the hospital frequently, seeing him during that time. And he lived an additional 6 months after that, but he never returned to his full vitality. The sepsis had further diminished his cardiac function, and he just had end-stage congestive heart failure. The cardiologist who I worked with to help him was very attentive and very thorough in his technical work on behalf of the patient, and I appreciated that very much, as did the family. He had, towards the end, had a dobutamine pump infusing through a PICC line, and then the last straw, he was admitted with a PICC line associated DVT in his arm. And at that point, I had been with the patient and the family on this journey through sickness and health and back to sickness again. And I was able to stand up on the stepladder over my patient and with the cardiologist working below and other specialists and say, this has gone beyond technical fix. The end is near. This is going to be a revolving door of hospital admissions that will not enhance your life. And I think it is time to take a different route. And the patient, in contrast to my other patient, that was a really hard conversation, but it was a possible conversation. It was made possible by the relationship, and the relationship was made possible by my faithful presence over months and years. And ultimately, we transferred him to an inpatient hospice facility we have here in Raleigh. That's a wonderful facility. And my last day with the patient, he was sitting in his room with the doors open to a beautiful spring day, and holding court, telling stories as he was really capable of doing. Wonderful storyteller. And he died peacefully a couple of days later. And in contrast to my lung cancer patient and to other patients that I saw in my outpatient-based primary care practice, this was a case in which I felt like I was in the place where I was supposed to be doing the work that I was supposed to do. And I was grateful for that opportunity and for that place. And the time and attention that it took to form the bond with that patient cost me a lot of time, but that is time well spent. I would much rather spend that time than be at home coding and checking boxes and doing all that meaningless toil. The place where we are supposed to be, the place where we belong as physicians, is at the bedside, is with our patients in their suffering. I get a little choked up. Talking about, because that is where we belong. We do not belong behind the computer, with a computer between us and the patient, doing some data entry that is diminishing and demeaning to us and diminishes our relationships with our patients. Push all that stuff out of the way, get back to your patient and take care of your patient. That's what you're here to do. I'd like to present one other case if I have time. And this is the case of a woman who presented to me in 2015 with right-sided, or actually left-sided buttock pain radiating down her leg. I'd known this woman about 7 years at this time in our meeting, and it seemed like sciatica. I referred her to a physical therapist. She had no neurological deficits. It seemed the appropriate next thing to do. Fortunately, she had a really good physical therapist who, after a few weeks, said, you know what, this isn't responding in the way that it should respond. I'm going to call Dr. Fisher and I want him to look at this again. He pointed out that her pain had migrated more towards her hip. I saw her back, and indeed, her pain was more in the groin at this point, but she had full range of motion, and I couldn't really figure out what was going on in her hip. I sent her for plain x-rays, which were normal. I asked an orthopedist to see her. He also could not find a cause. He did an MRI of her spine, which showed degenerative disease, but no focal lesion that would explain this pain. And he suggested that she see a psychiatrist. And she came back to me with unrelenting pain that was getting worse. And I, at this point, thought about, well, who is this person before me? I've known her for 7 years. She's a pretty no-nonsense school teacher. She's never expressed greater drama about her life than it deserved in the past. And so I can't explain this, but there's something going on in this patient's hip that we haven't identified. I thought maybe we'd find osteonecrosis of the hip, and I sent her for an MRI. Unfortunately, the MRI revealed a large tumor of the femoral neck that proved to be a non-Hodgkin's lymphoma and wasn't seen at all on plain film. She had a resection of the mass and a hip replacement, and then 6 months of arduous chemotherapy, and survived. Had a complete remission for 5 years until this spring, when she's fortunately had a recurrence of her lymphoma, but is currently being treated for that. And I raised that case to highlight again the importance of the doctor-patient relationship, not only for our patients to trust us, as in the case of talking about end of life, but for us to trust our patients. For us to know our patients well enough to know when they are manifesting physical symptoms of emotional distress, and when their physical symptoms need us to push further into physical concerns. So without that relationship, we are much more likely to, as this unfortunate orthopedist did, send our patients with lymphomas to psychiatrists. And in contrast, without that relationship and knowledge, we're also really likely to send our patients with depression to surgeons. And I say that not to disparage the orthopedist. The orthopedist knew the patient for one visit. I knew her for 7 years. I should have known better than he, who this patient was and what was likely going on with her. shame on me if I didn't know that. Unfortunately, that knowledge of our patients and who they are, and that gives nuance and enhances our ability to make diagnosis. That relationship is so much more difficult to achieve in our hurried and pressured atmosphere of care. Any human relationship that is based on mutual trust and care and affection needs time to develop. And it is not possible to send a patient and a physician into the room and say, you have 7 minutes and you have these metrics to hit and you have to check these boxes. And by the way, form a trusting and a genuine, sincere relationship that will help you navigate life's difficulties going forward. It just doesn't happen. And so this patient of mine who I was able to help diagnose, make an accurate diagnosis because of my relationship is just another example of why Sir Francis Peabody wrote in 1927 that the knowledge of our patients is central to our ability to care well for our patients. And that is the really concluding thought I'd like to leave you with, that our particular job as primary care physicians is to know and care for our patients as whole patients. And we need in our time to join in this 100-year-long and maybe longer struggle to defend the doctor-patient relationship amidst an increasingly technical-driven and technological and procedurally oriented healthcare system that leaves out the humanity in the relationship between us and our patients. And if you stand for your patient and you stand for the doctor-patient relationship, you're going to have to stand against things, because there are a lot of things that threaten that relationship. That relationship, we give lip service to it in our time, but the doctor-patient relationship is violated structurally every time you walk into a room with a third-party payer paying for that visit. They are setting the tone. They are in the midst of the relationship. They're telling you what you can do and how long you can spend. And you cannot form a relationship in that setting. So that you have to push back against that. And the only way, in the Life magazine article that I quoted at the beginning said, the physician was a trusted friend, and the only way to be trusted is to be trustworthy. I'd like to quote it. One more magazine article, and this one is from the Saturday Evening Post from 1963, in June 15th edition. This is, again, another from the patient side, looking at the disappointment that patients have felt over the last century as primary care physicians have done less than their full calling tells them to do. And the person writes, "The doctors in my father's time were honored and trusted personal friends, almost heroes, top-ranked, though never wealthy. They walked, they rode horses, but they got to the patient anytime. They weren't perfect, but their feet were on the ground, and they were people among people." We need to be people among people. We need to be people who can allow ourselves to connect our patients' souls and engage in our relational work. It's what we're called to do. It's what I encourage all of you to do. And I encourage you to throw off the shackles and the things that keep you from doing it. In my own personal journey, I've found that I can do that through direct primary care. And if you're interested in what that is, I'll be glad to talk to you in the question and answer session. But we are in a fight as primary care physicians, and we're not new we're not the first generation to this fight, but in our time, in our place, I encourage you to stand with Peabody, with the other greats in medicine over history, and fight for our patients and fight for your profession. Thank you.